Let me introduce Dr. Cocanour then. Chris Cocanour, you all know, is giving grand rounds today, and she's one of our longtime faculty members. She's originally from Ohio and received almost all of her training in that state. University of Toledo, University of Cincinnati, and then Case Western Reserve for undergraduate school, residency, and medical school. She did a trauma and critical care fellowship in the University of Texas at Houston, and then stayed on as faculty at Herman Memorial Hospital, where she rose to the ranks and had a number of responsibilities until 2005 when she was promoted to professor. 1 year later, we were fortunate enough to have her join our faculty, 2006, at the University of California in Davis. She, as you all know, is a co-program director for the Surgical Critical Care Fellowship along with Skeeter, and has been the longtime director of the Surgical ICU. He's most recently been president of the Western Trauma Association and president of the Northern California chapter of the American College of Surgeons. But her most recent accomplishment, one that's going to pertain to today's grand rounds, is her membership of the American College of Surgeons Committee on Trauma and the chair of the Best Practices Committee for TQIP. And from that position, she's able to greatly influence trauma care in America by developing guidelines for best practices for trauma centers across the country, which are then measured in TQIP and then are mandated during the site visits for a COT verification. So it's not just an honorific position, it's one that carries actually quite a bit of influence on how healthcare is provided. She's going to use this opportunity to talk about pain management guidelines, I believe, through both this committee and here at UC Davis. So, Dr. Cocanour, welcome. Thank you for grand rounds.
This has been something that, as most of you know that have worked with me, I've been a big proponent of really thinking about what you're giving for pain management for the patient and trying to avoid the use of opioids, because opioids are just bad news in many, many ways. And let's see. Here we go. So my only disclosures are what you already heard from Dr. Cherkovich, that I am the chair of the Performance Improvement Patient Safety Committee for the Committee on Trauma. And as part of that committee, we have the best practice guidelines. And the best practice guideline that's currently in development is going out to various other organizations to get their buy-in, is on acute pain management in the trauma patient. And I have to say, this was one of the ones that I was a big proponent of as far as our pursuing this as a best practice guideline, because I really don't think people have a good idea on some of the drugs that we use and how best to use them. So background is JCAHO published pain standards in 2000, and where they started referring to pain as the fifth vital sign. Along with that, about the same time, I'm going to bring this down, OxyContin and other drugs were being marketed in a rather misleading fashion, that they didn't particularly cause addiction, and oh, they're great. And with that, the expectation of patients, and for that matter, caregivers, became such that, oh, patients should not have any kind of pain at all. We should be able to get rid of all pain. And as you know, that is really not something that we can actually do. And this has led to the opioid epidemic. And these are just some numbers. 130 plus people died every day from opioid-related drug overdoses. And most of these numbers are from 2018 or 2019. 10.3 million misused prescription opioids in 2018. 47,600 people died from overdosing on opioids. 2 million people misused prescription opioids for the first time. And there were 15,349 deaths attributed to overdosing on heroin in a 12-month period, as well as 32,000, nearly 33,000 deaths attributed to overdosing on synthetic opioids other than methadone. So we saw a peak in the opioid prescriptions in 2010. This is in California, that you can see down in this little graph. And around here is 2010, where you saw prescription opioids, which is this blue line, and they've started coming down. And these are all overdose deaths. And some of this is because across the country there have been a number of prescription drug monitoring programs, sometimes referred to as PDMPs. We have cures in the state of California. And with that, as you look at the different state successes, and Florida, Ohio, Kentucky were three of the highest states with problems with opioids. And so this is a decrease in their opioid prescribing. And it dropped 80%, 85%, 62%. That's huge numbers. So practitioners are trying to make efforts to find alternatives to opioids, and without letting the patient have pain problems. But it's a culture change. If you ask the nurses on the floor what pain meds are they on, they'll only tell you the opioids. They don't tell you Tylenol. They don't tell you about NSAIDs. They only tell you about opioids, because in many people's minds, opioids are the only kind of pain medicine there is. And the other thing is, our goal, and this is something we have to educate our patients, whether it's a trauma patient after they come in, or your patient that you're getting ready to see in the clinic who's going to have a procedure, you need to educate them that we can't take away all the pain, but we can make the pain tolerable so that you can do the activities that you need to do. For example, if the patient has rib fractures, they need to be able to breathe. If it's somebody with a total hip replacement, they need to be able to walk and work with PT. So what is the pain physiology part? So it's a multidimensional emotional and sensory experience, and it's going to be different in every single patient. It's also going to depend on what is happening with that patient. Are they having pain because of a procedure? Are they having pain because they're in an athletic competition or they're in war? So it's going to change. And the patient-reported self-efficacy is a better predictor of satisfaction with pain management than the cause of the pain. This just gives you a schematic. You have the peripheral nociceptors, then goes into the peripheral nerve, and then into the dorsal horn, and up into the cortex, and then descending modulation. These are all areas of where our various drugs can work, whether it's opioids, the dissociative anesthetics, or we think maybe acetaminophen, some of the gating agents, so things like topical ice, heat, splinting or positioning. Spinal anesthesia would be at this level. Gabapentin, voltage-gated calcium channels, postsynaptic dorsal horn here. Regional anesthetics are affecting your peripheral nerves. So it really depends. And with continuing pain, the experience of pain produces changes in the spinal cord, the brainstem, and the cortical architecture to either amplify or diminish the sensation. And continued pain can lead to upregulation of receptors in the spinal cord and an amplified response to the repeated stimuli. And that makes your acute pain eventually transition to chronic pain. The chronic pain is actually a pain that it's continued perception of pain without an obvious or an ongoing automatic trigger. And this is something that there's still a lot of work being done because we really don't understand quite how this transition takes place. How do you assess pain? And it's a complex process, and it's difficult to fully quantify with any single assessment tool. We have, and many of you are all familiar with the unidimensional assessment tools that we use for cognitively intact adults. So hopefully most of the people sitting here would be considered a cognitively intact adult. The advantage is when you use something like this, it's quick to administer. It can be repeated. It's easy to trend over time. The disadvantages is that it's very subjective, and the patient has to be responsive. They have to be able to tell you if their score is a 5 or a 7 or whatever. And examples are going to be your numeric rating scale, your visual analog scale. The numeric is just where you ask them a number. The visual analog scale, you give them a strip with numbers from 1 to 10 and ask them where their pain lives. And then the Defense and Veterans Pain Rating Scale actually makes use of many of these. So you can see it has the numbers, it has the strip. It also has faces to be able to give you a better idea of helping for the patient determine. And as well, there are supplemental questions that help decide, does the pain interfere with your activity? So it hits a number of different things because so that's another one that can be used. When you have somebody who's cognitively impaired, it can be much more difficult. And these people are much more likely to have undertreatment of their pain, and their pain scores in this category really aren't equivalent to a self-reported score. Really all this does is it tells you whether or not you have the presence or absence of pain. It really doesn't tell you what the pain severity level is. And one of these that we oftentimes seeing used is behavioral pain scale, where they look at facial expressions, what's happening with the upper limbs, are they compliant with the ventilation if they're on a ventilator. Others are the Critical Care Pain Observation Tool, or CPOT. It's one of the ones that we use in our ICU here. And again, it's based on facial expression, body movements, compliance with the ventilator, or vocalization in those that are not intubated, as well as muscle tension. And then you get an idea of whether or not this patient is having pain. There's a couple of other things that have been used. So you have the I think probably most people know of the bispectral index, or BIS. Many times the anesthesiologists use it in the OR. We occasionally use it for a paralyzed patient in the ICU. It is something that many of these things are there to help guide analgesics, but they don't necessarily provide reliable results. So it's not something you want to just hang your hat on for a single number from these types of things. The other thing I want to also emphasize, because many times our nurses will give pain medicines because of their vital signs. Vital signs are a poor predictor of pain. There are many other things that can cause a change in your vital signs. So don't just necessarily give more pain medicines because their vital signs change. What you need to do is to look for something that might be causing pain. Do they really have pain, or is it because of something else? And then there are functional pain assessment tools, which were actually developed more for the older population, and it can be used in some of the cognitively impaired adults. Again, the functional pain scale that we heard about before, as well as the CAPA, which is a clinically aligned pain assessment. And this one actually, to my mind, makes more sense. This has been something that, again, when pain became a fifth vital sign, you always heard the nurses go in and say, what's your pain score? What's your pain score? The first thing they do when they go in to see a patient. So rather than, are you comfortable? What can I get to make you more comfortable? You're hearing a negative word. And to my mind, you start telling that to a patient long enough and they go, oh, they must think I'm supposed to have pain. I guess I'll have pain. And so I think it also depends on how we talk to people. But here are some of the questions that the CAPA looks at, and it's more of a functional type of scale. For example, functioning. For the usual things you need to do. Can't do anything because of the pain. Can do everything I need to. So those are different scales that people have tried to come up with a better way of being able to assess and follow someone's pain. In the older adult, again, self-report is most valid and reliable, but many times if you have someone who's demented, they may have cognitive dissonance or sensory impairments. These will all complicate the matter. And so an older adult needs to have more time to process the questions. They have to have time to be able to formulate an answer. And many of us, as we're really trying to push through to get done with everything we have to do, we may not give that older adult time to even think about what we just asked them. And I have noticed this, is that people do take longer just to process the question. Not only is it that they may need to have their hearing aids in, or they need to have increased font size when you're actually asking them, what are the numbers on this? Because They may not be able to see it without their glasses or even with their glasses. And I don't know of for those of you that are starting to get to the point where you need reading glasses, how often do you need to have more light to be able to read? Again, you may need to modify how you're interacting with the patient to be able to get adequate answers. And it's a hierarchical approach to the assessment. If they're cognitively intact, you can use the unidimensional or the functional pain scales. If it's severe dementia, then you might want to use the functional pain scale, Pain Ad, or DOLA plus 2, which are a couple of scales that have been specifically developed for those with severe dementia. And in those patients that are totally nonverbal, you have to look for evidence of pain behavior, such as guarding or grimacing, and also seek input from the caregivers and family. These are just a couple of, I don't expect you to be able to read through these, but these are a couple of the scales: the Pain Assessment in Advanced Dementia, Pain Ad score or scale, the DOLA plus 2 scale, which is a behavioral pain assessment in the elderly. And these, all three of these can be used for the demented older adult. There's also specific tools for the pediatric population. The FACES Pain Scale Revised. FACES is faces, legs, activity, cry, consolability revised scale. And they look at all of those things. I want you to think of pain management in the acute setting as a toolbox. We have all these different tools, and every single patient is going to be different. They have different allergies, they have different comorbidities, they have all these different things that play into what can be used. And so you take these different tools that I'm going to go over, and you use these to be able to provide the best multimodal approach to your pain management. There are non-pharmacologic pain management strategies. There are cognitive strategies that include pet therapy. How many times is it really nice to see the pet that's walking around and everybody it makes you forget your pain? You've got cognitive behavioral therapy, hypnosis, virtual reality, music therapy, mindfulness. And there actually have been studies. Sometimes the evidence is moderate. In virtual reality, it's actually high. And some of these cost a little bit more, others don't cost that much. There's also physical strategies. We heard last week that Dr. Farmer has her acupuncture certificate. So acupuncture, aromatherapy, immobilize the injured area, something that's very basic. The first thing you do when you have a bone that's broken? Immobilize it. It helps make it hurt less. Massage therapy. Temperature, whether it's cold or hot. Heat actually has been shown to be more effective than cold. There's iontophoresis, there's TENS, as well as portable ultrasound. Again, the evidence is varied, but really only cold therapy seems to be on the low evidence. But the others have at least some evidence for being effective. What about pharmacologic therapy? And these are non-opiate things that we're going to start with first. Acetaminophen. Everybody poo-pooed it. But I think what really made us think about it a little bit more was when it became IV. Now, the cost of IV is much more expensive than the other forms, which that's one of the reasons why it's a great drug, because it comes in many different administration routes. The exact mechanism of action for it is not really well understood. It may selectively inhibit COX activities in the brain. The addition of Tylenol to opioids decreases their morphine requirements. The thing with it, scheduled dosing is key. You have to get the levels up, which is again one of the reasons why IV therapy is much more effective, because it gets the levels up very quickly. It takes 2 or 3 doses of the oral regimen to be able to get you up to the same levels and keep them up. And keeping those levels up is why it's a much more effective drug. Obviously, contraindications are going to be for allergy or severe liver damage or disease. And as patients age, and in the older adult, so probably over 80, if you're going to keep someone on for a prolonged period of time, you may want to max out that dose at 2 grams rather than 4 grams. So our P450 systems don't do as well, and so as we get older. So the IV has a rapid onset of action, and the time to reach the peak Cmax is 30 minutes faster. And it will achieve 70% greater Cmax than the same dose of an oral. But over the course of time, the oral doses get up, and there's no essential difference between IV and oral in the reduction of pain or the oral morphine requirements that someone needs. So that really only that first dose may be really helpful if they've not been on acetaminophen before that. The other one that we don't think about often enough, I think, is NSAIDs. They inhibit COX-1 and 2. They inhibit prostaglandin synthesis through that. They're equally effective to opioids for acute traumatic pain. So they're just as effective as an opioid. And when used alone or in combination with opioids, it greatly reduces the oral morphine equivalents. Obviously, there are risks: GI bleeding, acute kidney injury, cardiovascular events. So these are mainly with long-term use, but the risks will vary depending on the COX selectivity of the drug. Antiplatelet occurs through COX-1 inhibition, so the COX-2 NSAIDs, like Celebrex or celecoxib, will have decreased interactions with platelets, and you won't really get platelet inhibition with those. Prostaglandins are what promote renal vasodilatation. And as we get older, many people are going to be at max prostaglandin just to keep the renal blood flow going. And so if you now give something that's going to inhibit that, that is where where it can become more injurious to the kidney. And concern for impaired wound healing. So for short-term courses, we're not talking months, but short-term, there has been initially a push by ortho, and that has now since gone away. Their main people have said, no, it's okay. You can give NSAIDs with fractures. It's not going to affect the non-union rate. There is, for those of us that do colon surgery, there is limited evidence in colorectal resection for increased anastomotic failure. So that is still out there, and I'm just bringing it up to make you aware. It's one of the reasons why you'll hear many of your surgeons say, no, I don't want to use Toradol postoperatively in my patient that just had an anastomosis. There are also NMDA antagonists. Ketamine is the one that's probably most well known. And we're not talking for pain we're talking about a subdissociative or subanesthetic dose. It's not the dose that anesthesia would use in the OR. It's an analgesic dose, and it's about 0.3 to 0.5 milligrams per kilo. Consensus guidelines recommend it as a perioperative adjunct in patients expected to have either moderate to severe postoperative pain or who have opioid tolerance. And as an adjunct to those with sleep apnea, it doesn't cause more respiratory depression. You do have to use it a little bit with caution in patients that have a cardiovascular history or who may have difficulty with a transient increased blood pressure, where that could be harmful. Although studies have now shown there was at one time it was not felt to be safe to be used in TBI patients, and that has since been reversed, and it can be used in TBI patients. Magnesium is another NMDA antagonist. At higher doses, MAG will decrease opioid requirements in the perioperative setting. You'll hear a little bit more about this further down in the talk. It's because it's currently under study at UC Davis. Methadone not only is a mu antagonist, it also has NMDA antagonist properties. And it may have opioid sensitizing and sparing effects when used in tolerant patients or at high doses. This has been something that they're finding, that if you give in the operating room, it may decrease the opioid requirements down the road. Opioids. So you can see opioids affect the alpha-2 adrenal receptor agonists. They also, they're here as well as here, both centrally and peripherally acting. Advantages, they're low cost. They have a variety of dosage forms, and we know that they work. It's why the question when I ask what pain meds are they on, the only answer I get is what opioid they're on. but they have dose-dependent respiratory and CNS depression. Avoid use with other CNS depressants. Really try and avoid somebody who's on benzos, skeletal muscle relaxants, gabapentinoids. The combination of all those with opioids can really make it possible for the patient to die just because they have respiratory depression. And we have seen it. And also, opioids, as you well know, delay return of bowel function, can contribute to ileus. You always want to try and administer orally when possible. And you use morphine or hydromorphone, i.e. Dilaudid, IV for breakthrough or rescue if you need to. The long-acting products are not something that you're going to use for acute pain. PCA, be aware that your PCA will actually end up letting the patient use more opioids. So it's something that I think you probably have seen less and less people using PCAs. And you begin your opioid tapering as the tissue healing process occurs. And the desired goal, ideally, would be not to have them on any opioids when they go home. And there's no ideal opioid. You want to select based on what the patient's specific factors. Is it a short duration of time that you need it for, like they're going to undergo a procedure? Fentanyl would be a great choice. You want to avoid morphine in patients with renal failure. It lasts a lot longer, sticks around a lot longer. So if you redose it more quickly, you may end up with higher levels down the road, so you can end up having adverse events with it. And I would always start with morphine over Dilaudid. One, we're using multimodal approaches. We don't need as much opioid. Dilaudid is a really power-packed amount of opioid in that small dose, and people forget. I've seen people give 1 milligram of Dilaudid without thinking, yet they would never give 10 milligrams of morphine, which is essentially, people will say, I was taught 1 to 10, other people say 1 to 7, but still, if you use equivalent doses of morphine, you're probably going to get a similar effect. But it comes in such a small amount, and we really don't think about it, especially in the elderly or the opioid naive. You can kill them. I've seen it. Gabapentinoids. These are drugs that will reduce neuropathic pain by inhibiting presynaptic calcium channels. And they will have been shown to decrease oral morphine equivalents in select populations, whether it's spinal cord injury or burn. You have to be very careful when you use it in somebody who has a substance use disorder. It's an additive CNS depression when used with opioids. The other thing is it's renally cleared, and it takes a while. As you start going up on your dose, that can catch up with you. We've had at least a couple of patients that I've seen that have been sent out of the ICU on gabapentin, and the doses increased, and they came back because they were totally snowed, had to be reintubated. So it's something, gabapentin, really only think about using it when you think you have neuropathic pain. That's where it's going to be best used for. So somebody who has an amputation would be a perfect patient for being put on something like gabapentin. And again, be very careful in the elderly. They don't metabolize these drugs very well. Oops, sorry. There we go. Then there are some other adjuvant analgesics, including your antidepressants, the serotonin reuptake inhibitors, tricyclic antidepressants, and they help when you have somebody who has chronic neuropathic pain management. There's evidence, is very limited in the acute pain population, but in the burn patients, it did show reduced pain intensity. Again, use with caution in patients with renal dysfunction and the older adult. They get drowsy and dizzy. And what happens when an older adult gets drowsy and dizzy? They fall, and they get to come visit us at the UC Davis Trauma Center. So, other things are antispasmodic agents. So, these can be used with muscle spasm. These are like cyclobenzaprine, methylcarbamol, diazepam. They also are sedating, and they require close monitoring of the patient. And methocarbamol use has been associated with a decreased length of stay in rib fracture patients. They get, their ribs are, the muscles between can spasm, and that may help. Alpha-2 agonists, things like dexmedetomidine, clonidine, may offer some opioid-sparing effects without respiratory depressant effects. Although the data in the acute pain model is minimal, unfortunately, both hypotension and bradycardia can limit their usefulness. One of the things that has been found is intraoperative dexmedetomidine may actually decrease opioid requirements. Lidocaine, not as much data is there for lidocaine. It has multiple mechanisms of action, a sodium channel blockade, inhibition of PMN priming, but most studies are in the perioperative setting. The patch efficacy is unclear, minimal concern for systemic absorption, although I guess if you start getting lots and lots of patches, you probably could increase it. But one of the things you have to keep in mind, if you have a regional block, I would avoid giving additional lidocaine because you have to worry about having a overdose. So regional analgesia, it's something we're starting to use a little bit more, but I would recommend you really, really, really try and use it anytime you're going to the operating room if you can. Continuous regional block can provide analgesia for days versus hours. Superior pain relief compared to systemic analgesia alone. It reduces opioid requirements, may decrease their length of stay because they're able to get up and move much more quickly. And it's one component of a multimodal pain management strategy. So epidural and paravertebral are the two of the ones that we see the most on the trauma service, mainly because we have a lot of patients with rib fractures. But both the epidural and paravertebral blocks can be used for acute post-op pain from lap or thoracotomy. It's preferred for bilateral rib fractures because you can do it with one procedure. Obviously, there's an increased risk of either hypotension, urinary retention, lower extremity weakness, and falls if it's in. The biggest risk, which is the one that I think anesthesia usually scares the patients with, is the risk of an epidural infection or hematoma. Which can lead to permanent paralysis or even death. The epidural is contraindicated in anticoagulated patients and relatively contraindicated in patients with a spinal cord injury or vertebral fracture. Paravertebral block, again, commonly used for pain, as I said, for lap or thoracotomy. The ultrasound guidance may result in superior analgesia and fewer complications like pneumothorax or bleeding. But the risk of bleeding with a paravertebral block is significantly less than an epidural, and it can be placed in patients with therapeutic anticoagulation. The disadvantages, there is a risk of pneumothorax. It has more limited dermatomal spread, so it doesn't necessarily go quite as far in the region as what an epidural would. And if you have bilateral rib fractures, you'll need it for both sides. These are a number of other blocks. Serratus anterior plane, used for the chest. Transversus abdominal plane, that's the TAP block, which excellent for the anterior abdominal wall. Quadratus lumborum block, more of the abdominal, pelvic, iliac crest. Erectus spinae, for the T2 to L3 anterolateral thoracic and lumbar area. Brachial plexus, femoral nerve, fascia iliaca. The fascia iliaca is one that we oftentimes see given in the ER for patients with hip fracture. And it pretty much, especially since obviously these are patients in the older age range, that they can completely avoid opioids. The block and Tylenol is usually all they need. So the local anesthetic systemic toxicity, it's something that you need to be aware of if you have patients that have these blocks. Mild manifestations, going to be lightheadedness, tinnitus, perioral numbness. Severe, either seizure or cardiac arrest, hopefully it doesn't get to that point, can occur immediately following placement of the block or up to 45 minutes after the procedure completion. Treatment includes giving 20% lipid emulsion. Multimodal analgesia. This is what we're now or should be doing in all of our patients. It's a use of multiple analgesics, regional analgesia, and non-pharmacologic interventions. All of those things we have just talked about. More than one of those becomes multimodal analgesia. It has potentiation of your medication effects and greater pain control without relying on any single class or medication or strategy. It mitigates the risk profile of each medication or strategy. But you have to consult patients again, going back to you have to help them with their expectations so they know what to expect. And this just gives you an idea of what you can, this is where you have pre-hospital emergency department as you come in with pain severity. And you may need all of these initially, but then as the tissue injury resolves, you'll need less and less of these. Again, I just want to remind you about that toolbox. So you want to give your non-opioid analgesics on a scheduled basis, whether it's acetaminophen or NSAIDs. Successful multimodal analgesia includes Tylenol, NSAIDs if the patient can have them, opioids, adjuvant analgesics, whether if they have neuropathic pain, add gabapentin. If they don't add it. And regional analgesia, cognitive and physical modalities. The tools that you choose are going to be used depending on the cause of pain, their allergies, their patient comorbidities, if they have renal failure, for example, etc. But don't use everything just because you can and because it's there on the order set. Think about and select what's most appropriate for that patient. Pain management in the older adult gives some additional challenges. There are physiologic changes that occur with aging that may alter both pain perception as well as response to medications. It's complicated further by coexisting illness, their concomitant medications, and even depression. Improper assessment, patient underreporting, and concerns about tolerance or addiction also further complicate matters. Some of the things that happen as we get older, there's a diminished response by the CNS to hypercapnia and reduced pulmonary reserve, which exaggerates the respiratory depression that you see with opioids and especially opioids in combination with benzos. You have decreased body water and an increase in adipose tissue that leads to higher plasma concentrations at equivalent doses that you would give to someone who's younger. And this results in increased side effects. There are variations in baseline prostaglandin concentrations, and that can increase the risk of both renal and GI injury with NSAID use. Age-related decrease in cytochrome P450 may account for the 20 to 40% prolonged metabolic clearance that we see in the liver. Diminished albumin levels result in larger free drug concentrations of highly protein-bound drugs such as NSAIDs, and prostaglandins that promote renal vasodilatation are increased at baseline in the older adult, and this increases the risk of renal injury with NSAIDs. I don't expect you to be able to read this. This is the Beers criteria. You need to be, if you are treating older adults, you need to be aware of the Beers criteria. Pretty much all of these drugs are things that we use for pain medication. And these are potentially inappropriate pain medication use in older adults. These are the potentially clinically important pain medication drug-drug interactions that should be avoided in older adults. Look, you've got opioids and you've got benzos, opioids and gabapentin, your gabapentinoids. So, again, be very careful when you use those drugs in combination, especially in the older adult. Medications generally considered safe to use in pregnancy for a short course are here. Tylenol, good throughout all 3 trimesters. Fentanyl, the same. Hydromorphone as well. Ketamine, only in the 2nd trimester. Lidocaine throughout, as well as your methocarbamol, morphine, and oxycodone. Notice there are no NSAIDs on this. We're going to move on to discharge considerations. There was no way I could talk about everything on pain, but I'm trying to pick out some of the things that I think would be of most benefit. The type, amount, and duration of opioids given at discharge has to balance the risk of inadequate pain control against the likelihood of sustained prescription opioid abuse, misuse, and addiction. The higher total dose, the longer duration is associated with greater risk of long-term use and misuse and overdose. Each refill is associated with a 44% increase in rates of misuse. Each additional week of opioid use increases the risk of misuse by 20%. And we've been really good about giving lots and lots of pain pills. In a Michigan study, the median number of prescribed pills was 30. The median consumption by the patient was 9. And so those pills just sat on their medicine cabinet at home. Or, sometimes those reach the street. Or the family friend or the family to the brother or the sister. 53% after C-section and 45% after thoracic surgery used either none or less than 5 pills. So people don't use as much as what we think they're going to. And there is a way of determining the risk for sustained opioid use. There are several tools that exist. None have definitely been validated. This is the SOS score that you see here, Stopping Opioids After Surgery score. It's intended for discharge planning to help decide who might be at risk so you can have a better conversation with your patient. The risk of sustained prescription use is 4% for a low risk, 17% in the intermediate risk, and close to 50% for those in the high-risk group. You have to educate your patients prior to discharge. The risk factors are associated with sustained use, anticipated plan for weaning those opioids, a timeline for transition to a non-narcotic analgesic. And the other big question that I see most people struggle with, how do you determine the number of pills to send somebody home with? What opioid to send them home with? So one note, and this is from our own toxicology people here at UC Davis. There's been a thought that if you give somebody something like Norco, which is combined opioid plus acetaminophen, that they're not going to be as useful for street value. That is nonsense. That giving a plain opioid with separate Tylenol is much better. It's not going to make any effect on how they're going to be sold on the street or whatever. It's not going to change the street value. And it's much easier to keep Tylenol scheduled when it's not in combination with an opioid. It also makes it a lot less mental gymnastics for the patient to figure out how much Tylenol they're on when they don't have to figure out what's in the narco, to be able to switch over from that. So it's much easier, just give them separately. The opioid requirement, 24 hours prior to their discharge, predicts the post-discharge opioid requirements. And the strongest predictor of opioid use at home in patients with abdominal procedures was the amount used just prior to discharge. So for example, if they had no opioids that were using the last 24 hours, they only used 1.5 pills when they finally went home. If they used 1 to 3 pills the day prior, they used 7.6 pills. If it was more than 4 pills, then they used 21.2 pills. This was from a study that was in Journal of American College of Surgeons. This is another study where they implemented a patient-specific tapering protocol at discharge. And they looked at the 24 hours prior, so you can see what the person was doing before in that 24 hours before they went home, and it gave them an idea of how much to prescribe. And this was for one particular procedure, but this can be extrapolated for the procedures that you do on a regular basis. This is just something that I wanted to put in just to remind. It's required by California law to offer a naloxone prescription and provide education to the patient and persons designated by the patient regarding overdose risk. And the patient would need this if they receive 90 or more morphine milligram equivalent daily doses of an opioid medication, or a benzo is prescribed with the opioid, or the patient presents with an increased risk of opioid overdose. Some of the things we've been doing here, and this is Lauren Coleman, who was in the lab last year and worked with me, and she's Jillian Holschel has taken over for her. But magnesium is looking at magnesium infusion for analgesia in critically ill trauma patients. It's an abundant cation necessary for numerous enzyme reactions. Animal studies in the 90s showed that it had analgesic properties. It's an NMDA receptor antagonist and regulates calcium influx. So we're looking at 156 trauma patients admitted to the ICU in a randomized, double-blind, placebo-controlled trial. And they get magnesium sulfate IV for 24 hours, or they get a placebo, normal saline. So the inclusion criteria, you can see here. Primary endpoint is what their opioid consumption is. And the secondary endpoint, pain scores, hospital stay parameters, and safety related. And these are some blinded results. We have not unblinded that, but because of being able to present for both the medical student project as well as for Lauren's project, we have group A and group B. We are seeing differences, so we'll see. This is with the first 40 or so patients. The inpatient multimodal order set was something that Jeremiah Doobie, Jin Lee, and I put together several years ago because we saw a need for being able to help remind people all the different things in the toolbox that you could potentially use. And it had general pain medications. It included neuropathic pain, it included inflammatory pain and spasm pain. Opioid supportive things like bowel care, antiemetics. Also included even field blocks so that you would even think about those. We actually looked at our results with this in a pre and a post study style. And we ended up with a pre-group of 65 patients, a post-group of 62 patients. And you can see this was a marked difference between those that were pre versus post on the cumulative opioid exposure. And so we increased our use of multimodal agents from 30% to 84%. So instead of being only on an opioid, they went to more than 2 agents. Decreased opioid exposure, 482 milligrams down to 126 milligrams. And there was equivalent pain control. If anything, it was better pain control. They aren't as sleepy. So this led, and our order set, our inpatient multimodal order set, was actually the basis for when the hospital decided that they needed a new pain management order set, which has just recently been released and that you're now having to deal with. There are information on this, and how to get to it. You go to the Insider, you go to the on-the-job resources, and there you see EPIC. Then you go to the upcoming current projects for the next on the pain management updates, and there are actually training materials. They give a lot of good information if you want to know more. So just some of the opioid best practices. Opioids should be laid on top of the multimodal regimens, not in isolation. Oral route, always preferred over the IV route if you can. Morphine is preferred for hydromorphine for opioid-naive patients with normal renal function. Start low and go slow. Don't let it catch up with you and then have the patient have a serious adverse event. The multimodal approach reduces the opioid dose required. You don't need as much opioids. And suggested starting doses are there as well. Supportive meds, don't forget those. And then we already talked about the naloxone and the education. These are some of the questions that have been coming up with the use of the new order set. The range orders have been removed. They've been removed for a reason. You want to use a rescue dose. And what is a rescue dose? It provides the nurse in order to give additional medication when the patient continues to have pain that's been unrelieved by their PRN dose. And the rescue dose can be either IV and or oral. You can have up to 3 rescue doses in a 24-hour period. If you're requiring more than 3 doses, then you probably need to readjust your pain regimen. You can also use a rescue dose as a pre-med for things like physical therapy. So when you would want to give an extra dose before they're going to do something, that's when a rescue dose could also be helpful. The keystone order is about the opioid order. So when you're changing from one opioid order to another, you don't have to go through and undo all of the things that go with that opioid order. You can DC the one opioid order, And then when you order another one, it's going to have all that stuff because it's going to take everything out that goes with that opioid order. It does not affect the non-opioid pain orders. Dilaudid versus morphine, we already talked, it's pretty concentrated. Use morphine first, especially in the opioid-naive patients. The multimodal strategy requires less opioid. A mild pain PRN order is not an opioid. It's going to be something like Tylenol. It can be an NSAID. It can be one of the non-pharmacologic strategies. And don't forget, your Tylenol needs to be scheduled, and if they can take NSAIDs, those are best used to be scheduled as well. Use those, and if you're going to give an opioid, they better be on one of those other two or both if you're going to start adding opioids, unless they have a good reason not to, like they're allergic. The opioid regimen should include moderate pain, severe pain, and rescue. Why separate acetaminophen and opioid? It's much easier to keep the acetaminophen going as the opioid is tapered. Much less difficult for patients to have to figure out what their acetaminophen dose is at home when not using the combination pills. And as I said, there's no difference in the street value. And educate patients to dispose of the excess pills. You want to try and get it to the point that they don't really have any excess pills, but then encourage them. There's lots of places they can do it, whether it's in CVS Pharmacy, Walgreens, or even in the clinic here or in the main hospital. Anesthesia PACU orders. They cannot be used outside of PACU. Don't use this as a workaround, i.e. where you change the phase of care from PACU to floor. Those PACU orders are there for one-to-one nursing. They have somebody that's there at the bedside. The floor obviously does not have one-to-one nursing, and it's dangerous. So just because you can get higher doses in the PACU, don't change the phase of care to get those higher doses on the floor. You will have dead patients. I'm going to stop there. It's right at 8:30. Sorry. And many thanks to Dr. Kathy Lammers, who is head of the Pain and Sedation Committee, who also helped with a number of some of the frequently asked questions that have come up with the new pain order set.
Thanks, Dr. Cocanour. Appreciate the grand round. I know the hour is late, but we would have time for some questions about the order set, perhaps, or about the use of narcotics, non-narcotics, or go, Matt.
Thanks, Chris. I have two questions. The first is, pain management has obviously become much more complex than back in the day. Many hospitals, including this one, has acute and chronic pain services. What would be your recommendation for if and when to engage those services to help manage these patients? My second question actually relates to your very first slide about increasing opioid-related deaths in California despite decreasing opioid prescription. To me, that looked a little discouraging that patients are, not prescribed, not using up their prescriptions and getting street drugs to, to get what they need.
I think,
So I guess those are my two questions for you.
so I think part of that is, keep in mind this includes heroin and synthetic opioids. Those are like things like fentanyl. So, and that's where you're seeing the increase. So this is the line for your synthetic opioids coming up here. So that's things like fentanyl. This is heroin. Whereas our prescription opioids are actually coming down. So it's still a problem. It's just that instead of going to, this is what the local drug people are using for, and fentanyl is dangerous. We know how concentrated it is. It's really, really, I didn't put that slide in, but when you look at how much it takes for fentanyl, it's easy to get a overdose. And then your first question was regarding the pain services. Ideally, you want to be able to work with your anesthesia pain service, which is acute pain service, before the operation if you can. Because they're the ones that can try and give a block, whether it's a tap block, an epidural, and that is significantly going to decrease. Now, we have an issue in that we've been told with our acute pain service that we can't get paravertebral blocks or epidurals Friday, Saturday, and Sunday, which means that then we have to come up with a way of being able to get that for our patients, because obviously our rib fracture patients come in still on Friday, Saturday, and Sunday. And so some of these things we can do ourselves. The fascia iliaca block is something that the ED docs put in for us. So you don't necessarily need the anesthesia acute pain service. The chronic pain service is basically an outpatient service. They really don't see patients in the hospital. You also have a third service, which is the pain pharmacy. And they provide a service, and they're actually useful, I think, when I have a patient who comes in on chronic pain meds, and it's difficult to get a handle on how much opioid they should be given, and you are afraid that you're going to snow the patient, and they help give a little bit of guidance. Now, sometimes I've found that they give a little bit too much guidance, like a little bit too much pain med, but when you have the really, really difficult person, that's sometimes who I'll get, especially if I have somebody who really is trying to play the different docs off to want more pain meds, and then we can say, we're following the recommendations of this pain service.
Well, it's after 8:30, so I think we'll time to quit. But I think it's, I think we're very fortunate to have Dr. Cocanour's attention to detail on the pain management and narcotics. It's such an important topic, particularly in today's society, for trying to adjust our use of opioids. That we have a faculty member who's dedicated to it is a real plus for us.